Okay, hello everyone. I hope you can hear me. Welcome everyone, and thank you for joining us. So this is the RedTalk webinar series dedicated to open innovation in the field of lymphoid malignancies. So today's episode is the fourth of the fifth season, and we are truly honored to welcome Irene Ghobrial from Dana-Farber. So Irene Ghobrial is a professor of medicine at Dana-Farber Cancer Institute and Harvard Medical School. She trained at Mayo Clinic with Dr. Bob Kyle before joining Dana-Farber. And so she's a physician scientist, she's seeing patients, and she's the head of an important lab focusing on precursor condition to multiple myeloma. So she's studying the evolution of MGUS and smoldering multiple myeloma to avert myeloma in terms of clonal evolution of the tumor microenvironment. She is leading as well large population studies, the PCROD study with more than 4,000 patients. It's also an initiative of empowering patients with precursor conditions of multiple myeloma, and the PROMISE project, which is a screening of the population with about 30,000 people who were screened for MGUS and smoldering multiple myeloma. So of course, the goal of all this research and project is to identify the high-risk MGUS and smoldering multiple myeloma and to be able to intervene early on and to cure potentially the disease by early intervention. So Irene will tell us today about this early detection and interception in multiple myeloma. Thank you very much, Irene, for joining us, and the floor is yours.
Thank you, Salomon, and it's really a pleasure and honor to be here with everyone. Again, next time maybe I'll be in France and not in the United States presenting virtually. So hopefully you can see my slides.
Not yet.
Now, yes?
We say yes, but...
Panelists say yes, so that's good. We don't see them, but we can listen to you.
Well, hopefully you see them soon. No? Nothing?
Salomon and I don't... Oh, yes. Yeah, now, yes.
Yeah, now it's okay. Yeah.
Okay, perfect. All right, so I'll try to take you in the next 30 minutes on why it matters to detect cancer early and to screen and to intercept early in multiple myeloma. These are my conflicts of interest. And I'll start by saying, and I know many of you already know what is MGUS and what is smoldering myeloma, but I'll start by saying it really matters to really understand the disease before it starts. And we're very fortunate that Bob Kyle, who's now over 95 years old, asked this question over 50 years ago. And he said, we are seeing small monoclonal proteins in the blood, but these patients do not have multiple myeloma. And in fact, him and Jan Waldenstrom were thinking of calling it benign gammopathy. And it was truly an amazing insight from Bob Kyle to say, no, this is not benign. There is something about this that can go on to develop myeloma. And let's call it of undetermined significance because we may understand better the disease. And that's really how we discovered what precursor conditions. And in fact, he was really insightful in this before we even now understand molecularly and biologically what precursor conditions are. So if you think about MGUS, very common disease, about 5% of the population over the age of 40 have MGUS. And if you look at the next stage before it goes to multiple myeloma, smoldering multiple myeloma, which indeed, as the name says, it is almost on fire, that's the stage when 10% of the population will go on to develop multiple myeloma every year, so 10% per year. And we know that there is a subset of those patients called high-risk smoldering myeloma that would be at risk of developing multiple myeloma in the next 2 years. So 50% chance of progression in 2 years. Now, the big question, of course, is how do you identify those patients? Within 100 patients with smoldering myeloma, 20-30% of them would likely have high-risk smoldering disease, but the current definitions and criteria are not extremely precise, and this leads to some confusion and may cause problems for us if we over or under treat some patients. Now, A year ago, if you had asked me what are we doing, I would have said we watch and wait until people have end organ damage, until our patients have fractures in their bones, lytic lesions, anemia, renal failure. Until most recently, the New England Journal of Medicine paper that came out with Thanos Dimopoulos and Vince Rajkumar showing us that indeed daratumumab single agent compared to observation has a huge difference in progression-free survival and overall survival. And in fact, when we were at the FDA in the ODAC meeting, as well as now EMA has also confirmed that indeed that matters and our patients will benefit from this. And I would say this is the beginning, not the end. This is the beginning for us to say indeed interception matters. Now the question is, what are we using for those patients? Which option of therapy? Should everyone receive daratumumab or other combinations of therapy or other options beyond daratumumab or combinations of therapy? So I think of our lab and our work in general as different stages or different pillars. Should we screen patients early because cancer screening saves lives? And I would tell you, if you had breast cancer, usually you say, let's screen every person and we do mammography, because if you identify DCIS early, you want to make sure you prevent cancer. Yet here in multiple myeloma and many blood cancers, we have a blood test, and it's much easier to do a blood test than mammography or colonoscopy, and yet we don't do it. And the next question is, even when we find MGUS and smoldering myeloma, and smoldering myeloma is a true malignancy, there is nothing precancerous in that stage. It's like finding stage 1 or stage 2 breast cancer. You would never tell a woman, you know what, you have early stage cancer, you're asymptomatic. Why don't you wait until you have metastasis everywhere, you have fractures in your bones everywhere, and then I'll treat you. In fact, that would be malpractice for us. Yet we do that every day for multiple myeloma. We tell our patients who have smoldering myeloma, why don't you wait until you have fractures in your bones, kidney failure, anemia, and then I treat you. And it doesn't make any sense for any cancer to wait for it until it has caused so much clonal evolution, immunosuppression, further mutations, and then you start your treatment. And in fact, I would argue that we probably have all of the amazing drugs that we need already in myeloma, but we're not curing patients because we're not treating them at the right timing. And if we just shift our treatment for an earlier interception, we may already achieve the cure that we need for multiple myeloma. So how do you do that? How do you define who is at risk or not? And I will not talk about the early detection and screening piece because that could be a lecture on its own. I will take you through the two parts of risk stratification. How can I identify a patient who is at risk for developing myeloma? Because we want to make sure that we're precise in our detection and we're not over or under treating patients. And then how can I potentially start the development of early interception? Because if I don't treat those patients, then why am I detecting them early? What are you doing other than causing anxiety? So it's important to think of early detection and risk stratification matter only if I can treat my patient and potentially cure them. Now, the first question is, what causes progression and how can I identify the patient who is at risk of progression? And you can see from the first schematic here that indeed it's a constant progression from MGUS to smoldering myeloma to myeloma. And the question is, when are those transitions happening and when is clonal evolution happening? Now, clinically, we use biomarkers that are static called the 22-20 classification. This is a simple way for us to detect patients by 20% plasma cells, 2 grams protein, or 20 light chain ratio. And if you use that, you can actually define who is clinically going to progress in the next 2 years. Now, the problem with 22-20, although it's a really good, simple model, is that it's static, it's not dynamic. So patients who are evolving very rapidly may still be 22-20 low, but you know that this patient is going to progress very rapidly. And there are some patients who have 22-20 high, yet they will not progress for many, many years. Now, these are the minorities, but trying to dichotomize patients and trying to put them basically like a taxonomy in different buckets is a problem because patients are indeed following a dynamic process. So with that in mind, we developed a new model called the Pangea model. And the idea of Pangea is that we're back again to all of us as one world and not divided, and trying to see if we can still use the same factors of 22-20, but adding to it hemoglobin and adding it to it age, and seeing if we can use trajectory models or continuous variables rather than static variables? And can I follow that evolving number of M spike and light chain and reclassify my patients every time? And hopefully soon we will have this on an app so that patients and physicians can use it and have this discussion with their patients. Are they truly high risk and should they go on therapy or not? Now, beyond clinical factors, you really want to look at the tumor and the non-tumor, the whole ecosystem, so the immune and non-immune microenvironment, and how that goes together to understand disease progression in our patients. So I'll take you first through the tumor compartment and then the non-tumor or immune compartment. The first part is the tumor compartment, and for many years, we've tried to understand how tumor clonal evolution leads to progression in multiple myeloma. And in fact, Salomon Manier and us worked on these papers together many years ago, where we actually looked at whole exome sequencing and targeted sequencing panels to see what are the mutations that lead to progression. And we found MYC alterations, MAP kinase mutations, DNA repair mutations that are critical. And in fact, this was the same with multiple other studies by Liefberg-Zegel and Gareth Morgan and Nikhil Munshi showing that indeed those alterations are critical. However, in a recent paper, Nature Genetics with Jean-Baptiste Alberge, we wanted to say, well, beyond those mutations and copy number alterations, can I put everything together? Rather than saying MYC is important, KRAS is important, can we create a comprehensive, simple myeloma score model, where if I have this score high, then I know that I'm going towards myeloma. And if the score is MGUS-like, then I know that this patient will not progress to myeloma. And we put together 24 events, the events that go towards myeloma, minus the events that basically are only seen or seen more commonly in the MGUS, which are the MAF and MAFB. And basically you create a balance of one minus the other and see if you have that balance towards myeloma or towards MGUS. And by creating that, you can see indeed that that myeloma-like score, which is a very simple score, can actually precisely tell you who's going to progress or not. So you can see the numbers are going up from MGUS to smoldering to myeloma, and within smoldering myeloma, you can see people who have a lower score are in the low-risk smoldering myeloma stage of 20-20, and the higher score is in the high stage. And this was validated in an external validation cohort, as well as our own internal validation cohorts, as you can see in the Kaplan-Meier curves. Now, the next question we said is, well, beyond just the genomic data and the genomic score, can I use the tumor mutation clock-like to understand actually the age of the tumor? And by using the age of the tumor as a biomarker, can that be added into the model? Which means that if I have a very old tumor, likely that will progress to myeloma. And if I have a younger tumor, that will likely be more MGUS. And indeed, by calculating the clock-like mutations, you can see that MGUS in general has about 15 years of age, and myeloma or even high-risk smoldering myeloma is around 30 years of age. Now think about that. By the time we diagnose our patients with myeloma around age 65, they must have had this early event happen in their 30s and in their 20s. And that's critical, one, for us to understand when should we screen our patients, and two, it shows you how long it takes for the cancer evolution to happen for our patients to start having symptoms. But potentially, clinically, you can use this as a simple clinical biomarker that can help you indeed say who will progress and who will not. So putting that together with whole genome sequencing and DNA sequencing, we said, well, that's great, but it's bulk sequencing and it's DNA level only. And we know that there are so many epigenetic changes and transcriptional regulation changes beyond what happens at the DNA level. We used to think that the hallmark of all clonal evolution and changes in cancer is DNA only, and that was the holy grail. Yet we know now that epigenetics and transcriptional changes that occur because of the macro and microenvironment are critical in disease progression. So the next step we said is, why don't we go to the single cell level and really look at the whole transition from early disease, healthy MGUS, smoldering myeloma, and myeloma, using single cell sequencing and BCR sequencing to really identify transcriptional changes that can predict progression. And this is work with Gary Getz at the Broad Institute, where indeed we looked at 1.7 million plasma cells and really looked at that transition stage across the cohort. And here you can start asking a lot of questions. The first one is, are there differences at the genomic level that I can identify instead of cytogenetics, but genomically at the transcriptional level? Can I define what are those hallmark changes that happen early between healthy to MGUS and MGUS to smoldering myeloma and smoldering myeloma to myeloma? Can I develop a myelomatous model, basically just like the one that Jean-Baptiste developed at the DNA level, but at the RNA level, that can predict accurately who will progress and who will not? And can I look at the intra-patient heterogeneity rather than the inter-patient heterogeneity that we do when we do bulk sequencing? So the first question was, can we look at potentially some of the immunophenotypic changes that occur at the intra-patient and within that clonal dynamics and clonal heterogeneity that occurs within each patient? And I say that because right now we put patients into buckets again. We say, you have myeloma. And sometimes we even say, oh, you have an 1114 or you have a 414. But we don't say within your cells, which cells have a high GPRC5D level and which ones don't. Or within the MAF translocated patients, which ones have a high level of a target and low level of a target. And that's critical as we develop precision interception and precision therapy in our patients. We need to be more precise in saying a patient with high level of GPRC5D on almost all of their cells will benefit from GPRC5D drugs versus others. A MAF translocated patient may benefit from certain therapies versus others. And the more precise we are, the more our therapies will give us a higher impact. The next question was more biological. Can I really understand the first stages of change that occur from a healthy plasma cell to an MGUS cell and vice versa to smoldering or to myeloma? And potentially you can use that information for two things. One, it's a biomarker because you can tell that indeed that cell transcriptionally is still in the MGUS stage. But two, therapeutically, if you have certain identifications of the MGUS stage or smoldering or myeloma, then I can be again developing therapies only for that stage. So if there are certain changes in MGUS, I can use therapies only in that stage. So here's the first data of healthy versus MGUS, and the genes that were regulated in this were mainly in immune evasion. And that makes sense. The first stage that changes is immune evasion because now you have that equilibrium between the myeloma early MGUS cells and the immune microenvironment. The next stage, at the stage of smoldering myeloma, were genes regulating cell adhesion and morphological changes. And again, that makes sense because now you'll start seeing circulating tumor cells and further disease progression in the smoldering stage when the cells are going in and out of the bone marrow and having less adhesion. Again, potentially an area of development of therapeutics that we have not talked about before. Then the final stage is the myeloma stage. And now you start saying this is really at the inflammation stage. And now, again, you identify novel targets that can be used at the myeloma stage that were not seen previously in the earlier stages. And by doing that, again, you can use it for a biomarker of what is the transcriptional stage of that disease, as well as for potential therapeutic interceptions. Then the third step was, well, this is all great, but if you do that only in the bone marrow, you're missing a lot of the information. One, because circulating tumor cells in of itself is actually a prognostic marker. The cells, when they try to circulate, they're capable of doing much more than while sitting in the bone marrow. And two, because clinically it's much easier to take a peripheral blood sample and serially annotate that patient information. So can we use the information that's from circulating tumor cells at the prognostic level of yes or no, you have a lot of tumor cells, but also transcriptionally? And can I develop this all into one test that's simple? Can I use a blood sample from a patient, say, what is the number of circulating tumor cells, what transcriptional changes are occurring, and can I potentially even say if it can replace fish in the bone marrow? So do they have a 1114 translocation? Can I get that information at the RNA level? So this work was done again by our team with Romanos Pistofidis and Liz Lightbody, where basically we took 190 samples, peripheral blood versus bone marrow, and asked the questions of circulating tumor cells versus bone marrow. Now, I can tell you that Liz and Romanos are Taylor Swift fans, so they decided to call this the Swift-Seq, and we haven't told Taylor yet, but basically this Swift-Seq is a method of us trying to look at the information in the peripheral blood, not only for quantifying the samples, but for also identifying cytogenetic changes as well as transcriptional changes in those patients. So this paper hopefully will be out in Nature Cancer in the next couple of weeks. And again, from 1.2 million cells, you can see differences between normal and malignant and between bone marrow and peripheral blood. And the first thing, which is again very simple, can you use this to be more accurate in your quantification? Instead of using flow cytometry, because it can never tell you if this is truly a malignant plasma cell, since we have BCR sequencing, VGJ sequencing, I can be more accurate in saying that plasma cell is indeed a malignant plasma cell. And you can see that in almost all of the patients, we can find at least 10 cells. And I'll tell you why 10 cells is important. And in fact, most of the patients, even at the MGUS stage, will have some cells circulating. And the more cells circulating, the more the disease is progressing, which is expected in those patients. Then what Romanos developed is a confusion matrix to actually say, can I predict which translocations those patients have in their bone marrow? So the ground truth is in the x-axis, which is FISH or whole genome sequencing from the bone marrow. And you can see those patients have hyperdiploidy or 1114 and so on. But then the prediction model from RNA sequencing in the blood can tell you that we can precisely predict it in almost every patient here. And this can be done 90% of the cases when you have 10 cells or more. So it's accurate and precise if you have 10 cells circulating. And indeed, the one patient who had 2 clones, one 1416 and one hyperdiploid, the 1416 was only present in the blood and not in the bone marrow. Now I'll take you to the immune microenvironment. And again, this is just scratching the surface because there is immune and non-immune, and we haven't even talked about the stroma and the non-immune microenvironment. And we're now taking it into the spatial transcriptomics rather than only looking at the single cell sequencing without looking at the spatials level. So we have a big H10 grant, which is part of the original Biden-Moon shot, where we're looking now at the spatial transcriptomic data. So this review here that we put together in Nature Review Cancers last year shows you some of the alterations that happen early on in multiple myeloma and then how advanced myeloma looks like. And this is critical because our hypothesis was that the immune system is much better and more fit at an earlier stage of MGUS and smoldering myeloma. And if I'm going to use immunotherapy, I should probably be using it as early as possible. So to answer some of those questions, again, Romanos was Ting and Yoshi put together 877 samples from tumor and immune, from bone marrow and blood, and we really looked at the whole spectrum. And this is one of the largest immune atlases of one cancer type, looking truly at the transition stages from precursor to malignancy. And we did immune single cell sequencing, 5' and TCR sequencing, as well as the tumor cells, CD138 positive and PCR sequencing. And by doing that, we ask questions of, can I look at the behavior of the immune system over the transitions, and can we identify, again, biomarkers and potential therapeutics that can happen, that can help us, but can we understand the changes that occur and when do they happen in those patients? So the first thing is compositional changes. And here you can see that the compositional changes that occur from MGUS to smoldering myeloma to myeloma, again, are well identified, which is the CD4 naive T cells increasing, central memory T cells, CD8 TEMs, CD16 monocytes, and the ones that are decreasing over time are plasmacytoid dendritic cells and CD14 monocytes. But that's only compositional changes. So now the question is, can I identify the changes that occur during disease progression? And the first thing we said is, well, those patients are also older when they have myeloma versus the ones that have MGUS. So let's correct for immune aging. So we looked at the healthy controls, corrected for immune aging first, and then added only the MGUS and the myeloma so that we can keep the smoldering myeloma stage as the cohort that we can validate the signature from. And here you can see that indeed what we found was that the granzyme B CD8 TEMs and cytokine positive CD14 monocytes are the ones that significantly change from the early healthy and MGUS controls to myeloma. And then when you use the smoldering myeloma and ask the question, are these truly critical, you find not only they're important for progression in smoldering myeloma to myeloma, but also they are correlating with cell cycle regulation. So you can see the tumor cells, when they're cycling, there is a significant increase in the granzyme B CD8 TEMs. And that starts giving you that association between the tumor cells compartment and the immune cell compartment. And we further validated many of the cytogenetic changes that occur in cancer cells, especially P53, and the immune dysregulation that occurs in a mouse model with the Spanish group. Now, stepping back and saying, well, this is all based on compositional changes. And we're so used to doing that because we're so used to doing flow cytometry. But if you step back and say the power of single cell sequencing is that you stop looking at the compositional changes and actually allow within NMF to really look at signatures of transcriptional changes that can go on across the different immune cells. And here you can see that we have several immune signatures. And one of those, interestingly, was a pan-cell type interferon signaling, which is S27, going through across many of the immune cells and not just one type of immune cells. And the other one was S26, which is again related to IL-1 beta and CCL3 and CXCL8. And just looking at the interferon signaling, where is this coming from and driven by? And it was driven by the tumor signatures and the immune signatures, both of them contributing to this high level of interferon signaling. Now, usually you think that interferon is actually an anti-cancer. If we give you interferon, that should be a treatment to prevent cancer. But in this case, it was actually counterintuitive, and it was actually increasing during disease progression. And we found the same thing in the mouse model, showing you that indeed, because myeloma is a B-cell malignancy, it's part of the immune system. The feedback with interferon is actually probably unrelated to solid cancers and related to a different way how the immune cells interact between them, B cells and T cells and so on. So this is critical because what we used to call exhaustion T cell markers and other markers that we have validated in solid tumors may not be relevant in hematological malignancies. And we have to be careful not to put data that has been taken from other cancers into multiple myeloma, including the T cell exhaustion markers. Finally, looking at T cell clonality, we started to ask the question of the T cell repertoire and whether that can also be used as a biomarker. And here you can see that from MGUS to smoldering myeloma to newly diagnosed myeloma, your diversity of the repertoire actually decreases significantly. And that's mainly driven by small subclones of T cells that are expanding in response to the cancer. Now, we don't know if those are tumor-specific T cells or TCRs, and we're actually actively looking at that because potentially these could be therapeutically used, but we're also using that change in the T cell repertoire diversity as a biomarker of disease progression. And indeed, you can see that it validates in COMPASS that the less diverse you have, the worse the prognosis in those patients. So taken together, this data, we started saying, well, can we apply this with immunotherapy in clinical trials? And we know that daratumumab, we know that Lendex have shown benefit in smoldering myeloma. But the question is, can I bring the best drugs that we have of immunotherapy, meaning bispecifics and CAR-T and potentially vaccines in the future to really prevent and intercept multiple myeloma? So the first trial that we designed was using teclistamab, which is a BCMA CD3 bispecific antibody. And here we randomized the patients 2-to-1 to lenalidomide and dexamethasone versus teclistamab versus, again, any other arm of that study to open. It's a platform study, so we can add a trispecific, we can add other things. And I can tell you that we're almost done with accrual, but I'll show you only the data for the first 12 patients because we presented this data in ASH. So the first 12 patients, as you can see here, had a 100% response rate and 100% complete remission and MRD negative disease. So this data has been updated, of course, and we know that MRD negative disease, 10 to the 6th, not 10 to the 5th, was present in all of those patients. And the other thing that was critical is these patients did not have a higher infection rate, which was a big problem that we were worried about when we were treating those patients in a smoldering myeloma setting. You don't want to cause harm. So indeed, we saw less infections compared to relapsed myeloma, but a significantly higher, significantly improved response rate in those patients, adding to that hypothesis that indeed, or validating the hypothesis that indeed, if you use your immunotherapy as early as possible, it matters for those patients. And the next trial, of course, was asking the question of, can I use CAR-T, which in this case, cilta-cel, in high-risk smoldering myeloma? And I can tell you when I proposed the study to J&J, and took a long time to try and convince them. And then I went to the FDA and submitted my IND. The first sentence in the response from the FDA was, absolutely no way. There is no way you can use CAR-T therapy in smoldering myeloma when it is supposed to be for relapsed refractory myeloma. And it took us several discussions. And indeed, it was an impressive discussion with the FDA because they said, okay, you can try it in 20 patients to look at the safety. and to do it very slowly. Every 3 months you can treat one patient, and then give us the data back again every 3 patients to see the data before you treat the next one. So this was truly an amazing collaboration between academia, FDA, and pharma to ask a very important question: could we potentially use our best therapy, which is T-cell cellular therapy, without any induction therapy, just CAR T? So you mobilize your T cells and you reinfuse them without giving anything other than fludarabine and Cytoxan, and see if that will potentially lead to an amazing response in those patients. And again, I'll show you only the data for the first 6 patients. And here, this was presented in ASH last year, and we're hoping to complete accrual this year, where we showed 100% of those first 6 patients having 10 to the 6 MRD negative disease, and again, minimal toxicity with this, proving again that if we do it correctly, you could potentially make a difference by using your best drugs, not just regular drugs, your best immunotherapy, when you have less tumor burden, less clonal heterogeneity and evolution, and a much higher or a much improved immune fitness in those patient populations. So I know I speak very fast, and I hope I took you through the journey of what we think of in smoldering myeloma and why we believe that early detection and early interception matters, and potentially will be the final hard way to get to, but the final pathway for cure in multiple myeloma. And I took you from whole genome sequencing, tumor cell level, single cell RNA sequencing, into immune cell sequencing. Again, in the future, we'll talk about transcriptional regulation, and then really taking you through the T cell clonality and interference signaling and how that matters, and then taking you into the clinical trials and applying them. And again, the future is big, trying to ask big questions of immunotherapy even earlier. Can we develop vaccines? Can we develop precision medicine, even looking at specific TCRs? Can we look at the spatial environment in those patients, and really understanding better the disease even before it starts? So with that, I'd like to thank, of course, our wonderful lab and clinical teams, our collaboration with Gary Getz. In fact, Salomon was the first one to work with Gary, and since then we've been working very closely on all our work together. And then, of course, our funders, NIH, MMRF, Leukemia Lymphoma Society, Stand Up to Cancer, CRUK, and above all, our patients. Thank you.
Okay. So thank you very much for this presentation. And I have several questions, of course, and we will take questions from the chat and a question from direct. We are speaking for all the chat, Salomon. So if I understand well, your idea, of course, is to treat early before the pathology is coming. So I totally agree with you. It's totally logical. And my question is, do you think you have to treat early, but you have to treat according to a genomic specific abnormality and not take all the patient as the same patient?
Yeah, it's a great question. And you're right? We do that mistake in myeloma. We put every myeloma in the same bucket. And we have an opportunity in smoldering myeloma not to do that, and to stop using only clinical biomarkers to say this patient is high risk smoldering. I would argue that a P53, 1Q, 414 translocated high-risk smoldering is probably worse than an active myeloma who has only an 1114 or hyperdiploidy. And we do need to design trials based on the genomic high risk rather than based on are you high-risk smoldering or overt myeloma. And maybe that can help us in understanding better the disease classifications of the patients, as well as developing therapies. So some patients may benefit from certain therapies and others, their single agent could be good for one patient, and then immunotherapy could be very good for another patient. I don't think all of them should be treated the same way.
And the duration, you show us some daratumumab treatment during only 3 months for patients with MGUS. You think it's possible to increase this time, or really that's enough?
So the daratumumab trial that was done, which was the Aquila study, was 3
Yeah.
years, and it was for high-risk smoldering myeloma. The current trials that we're using with bispecific antibodies are 2 years, although now we cut it to only 1 year because we don't think we need more than 1 year of therapy because they're achieving such a high response. CAR T is a one and done, so that's the beauty of it. But to your point, there is a clinical trial that we're doing now of bispecific antibody for 3 months or 6 months only for lower risk smoldering. And I think that's beautiful because you could potentially say you're that precise, almost like an excision of a polyp, right? You're going in, you're taking something, and you're done. 3 months of bispecific therapy, and you're done. And I'm hoping that this will really achieve that long remission for a long time, because that's that balance between toxicity and response in our patients.
Salomon, maybe? Yeah.
Yes, no, again, wonderful presentation, Irene, as usual, very interesting and super impressive work at all levels, in the lab and in clinical trials, so very interesting. Yeah, it was kind of related to the first question in your 6 million single cell sequencing, which is super impressive, and I hope the paper will be out soon. So you told us that, for example, there is a correlation between the cycling of the tumor cells and the granzyme B, T cell, whatever proportion of frequency. And so the question was, were you able on this huge data set to correlate the molecular profile of the tumor with the immune profile, immune microenvironment profile?
Yes, so that's the beauty of having that. Having said that, because the numbers of patients who have an 1114, a 414, a 1Q, and so on will get smaller and smaller, your power will be less to really identify those. But yes, there was a strong correlation with the patients who have a 17p, p53 with certain immune dysfunctions. And that starts telling you that actually the tumor does affect the immune system, right? Because we always said, oh, maybe there is no correlation at all, and any cancer will cause certain immune dysfunctions. But it is truly, it does actually cause that immune evasion and immune exhaustion as you go on. And even the signatures of immune exhaustion are very different than your traditional immune exhaustion. There was a paper that came out recently in Blood that says, immune exhaustion does not occur in multiple myeloma. And I would argue the traditional markers of immune exhaustion that we are used to see in solid tumors may not be the same in multiple myeloma. And we need to have that ability to rethink what is exhaustion in our T cells in a myeloma.
How do you imagine to apply all the score? There is 20 to 20, there is your myeloma-like score. And how do you imagine you can, which one first, which one will help? Does your myeloma score help to discriminate the 20 to 20?
Yeah, so we're in the era of AI, right? And this is the time of big data and allowing everything to be put together. And you can have a genomic score, an immune score, a single cell score, but the idea is that you put them all together and create a universal, more precise score. And this is what we're hoping to do in the next 5 years, is really put all of this amazing data together to create a much better model for our patients that is truly dynamic and reflective of their disease and more precise and accurate, so that we can then, like you said, have specific therapies for the specific patients and stop dichotomizing things or using only the DNA data or only the tumor data, because it's truly one system, and we should stop trying to say, I'm only looking at this because that's what I believe in.
Yes, sure. Totally agree.
This is very important, very difficult be able to incorporate everything. And you see kind of liquid biomarker. You showed us the CT classifier. Very interesting. So do single cell.
We don't hear you well, Salomon.
Oh, sorry. Can you hear me?
Yeah.
Okay. So you told us about the CTC classifier. And I think it's very interesting to detect the circulating tumor cells and the single cell sequencing on patients with MGUS, smoldering, whatever, and I think you can assess the translocations as you showed us, right? Based on the transcriptional signatures. So do you take? I mean, how do you do it? Because 10 cells is of course not enough for a single cell sequencing. So you have to enrich perhaps and then load some PBMCs and needs, and then select the cells that are tumor cells, or do you truly need to load only tumor cells?
Yeah, so it's a great question. It depends on the technology, and even now that this paper is coming out, we're already using an even better technology. Instead of the single cell RNA sequencing, we're now working with BioScribe to do single cell DNA and RNA sequencing. So you get the whole genome sequencing at the single cell level, but you also get the RNA signature from the same cell. And that takes you down to one cell. You do have to enrich before you do that, just so that you don't sequence a lot of normal cells, which is a lot of money wasted. But we showed some of that data in ASH last year, where post-CAR-T or post-teclistamab, even if you have only 7 cells in the peripheral blood, you can actually isolate those. So we do flow sorting, which is, anyone can do, and depending on your antibody panel, you can be pure. And then, of course, you can get your purity by knowing at the DNA level if those are pure cells or not from the copy number alterations and the VGJ sequencing. But now you get DNA level and RNA level from single cells. You can pool them. You can do small little pools. So we can do 5 cells, 10 cells, because it's easier to call translocations and copy number events and mutations. But you can also get single cell level, and now you can look at the phylogenetic tree and persistent cells post-therapy and so on. So we're hoping that will be the next evolution from the single cell RNA sequencing. For single cell RNA sequencing, you don't need to flow sort. They don't have to be extremely pure, but they should be as pure as possible, because you're putting those cells, and you need to have at least 1,000 cells for you to have information from them. What we did is, even if you have only 10 cells within the pool of cells that you're sequencing for 10x, you could potentially identify enough with good accuracy that those B cells, and again, they have to be clonal by VGJ sequencing, that indeed those cells have the transcriptional regulation. And for that one, you can only call things as big as 1114 cyclin D1. You're not calling, of course, mutations. So I think the newer technology will probably give you much more resolution of and depth of knowledge.
We have all in some cell in some patients interference signature, and to date it's impossible to find an explanation of why not. And I agree, we have the similar result. If you have interference signature in the tumor, you have it also in the microenvironment. And the idea is which one is the first and which one is responding. And for me, interferon is also a differentiation factor for B2 plasma cell. And I was wondering whether with your huge number of sample, did you see any relation with something with differentiation or not at all?
That's a great question. We should definitely collaborate on that. We did not look at that. And I wonder if we should, with all of the data, really go back and look at the B cells and how they're differentiating. Absolutely. I think that will be wonderful to look at.
And what we observe, because we identify as well this interferon signature, I think it's clear now, immunotherapies, it's also associated to NF-kappa B in the tumor cells. So I think it's, I remember well, Irene, it's something that you as well observe. So the more there is NF-kappa B activation in the tumor cells, the more there is this interferon signature in the immune microenvironment.
Correct, yes. I agree. I think there's so much to be done to follow this, right? We can identify things first, and then the insight from it and understanding functionally what's responsible for what is the causation rather than the association is very critical.
But
And
we see, oh, sorry, Catherine.
Go ahead.
I was thinking that you showed us the heterogenetics of Gammopathies initially, the clock, whatever, right? And I think it's interesting. I don't know if it's out yet or it's in press, but I haven't read the paper yet. But anyway, and so you told us MGUS, usually it's 50 years or of evolution from, I guess it's the phylogeny, so from the first mutation is assessed to years, multiple myeloma, 30 years. So if we think of that, then it's just accumulation of time and mutations. But we would imagine that perhaps in some like contexts, you will get a different mutation that will actually drive the progression, and it's not like a linear progression. At some point, boom, you will have progression. So I guess you have a diversity of patterns in evolution across the time.
Yeah, so it's a great question. And if we can create the evolution, what you're asking for is you can say at the beginning and the end, but you don't know how fast that timing, that dynamic disease progression. And we know from M spikes, we know that, the original Bob Kyle data, because we're lucky enough to have biomarkers. And if they are truly associated, not always, then you have some that, are slow forever and then suddenly hit. Could be the second hits and so on. There are some that are just constantly progressing. So it would be great to look at clonal evolution with this dynamic understanding of what is what are the patterns of progression. I think that would probably require multiple sequential samples, and this is where we're trying to get to that level of taking samples, and again, peripheral blood is easier, and multiple sequential samples, and then recreating those phylogenetic trees and asking when is not only the hit happening, but is this relating to that clonal dynamic progression?
Yeah, because we can think that a myeloma that's, say, 10 years old would be more severe than a myeloma who's 30 years old, because evolution was much faster.
Well,
that way.
yeah, exactly. If you had inactive myeloma and then it's the younger myeloma, more aggressive, but at least from what our data, it says a young cancer cell isn't more an MGUS1, any older cancer cell is probably a myeloma 1. It had that 30 years of being mature.
Between
Tells
30,
us that, oh, go ahead, sorry.
no, okay. Because you said progressors were 13 years and myeloma 33, so it's very near. Finally, 3 years only. It's 10% difference. Is it you think a cutoff and then everything will happen?
No, so myeloma or high-risk smoldering myeloma was around 30, and then MGUS was around 15 or so. So basically a big difference between them, almost.
Yes. But
Yeah.
between progressor and myeloma, it was 30 and 33.
No, but so high-risk smoldering, which is the progressors, were very similar to myeloma. They basically look like myeloma.
Yeah, agree.
Yeah.
We have questions from Jérôme Moreau in the chat. So many thanks for the great talk. We could expect more efficient immune cells in the precursor stages compared to the myeloma patient. Do you think that single-cell sequencing could allow the establishment of signature to define specific immune-based therapies dependent on different subgroups? Possible choice between monoclonal antibody or bispecific antibody?
Yeah, it's a great question. Not only that, can we do personalized therapy, right? So there is now neoantigen vaccines that are very personalized. Can we get to that level, not only of can I identify an antibody versus a bispecific versus CAR T, but can I also do true personalized therapy of vaccines that are specific and unique to each patient, and so on. So the future of immunotherapy is huge if we understand it correctly.
If I can go on this question, finally, don't you think that we have to target macrophages in patients rather than T cells? Or T cells for MGUS, and then maybe more macrophages to be the target, no?
Yeah, I mean, the myeloid compartment is so under studied, and we know that there's so much of immunosuppressive effects from it. In fact, I was just listening last week on questions of CHIP mutations, AXL1, DNMT3A, and all of those, and how they affect not only the microenvironment and inflammation, but they can also affect T cell exhaustion. And if you delete ASXL1, it will actually lead to stem cell-like T cells that can be better CAR Ts in the future. And they're applying that in some of the leukemia CAR T trials that they're developing. And I thought this is fascinating because we can really start manipulating the adaptive immune system and the non-adaptive and really understand how the whole compartment works together. So again, we're scratching the beginning and there is so much to be understood here. We didn't even talk about stroma, osteoclast, osteoblast, hypoxia, inflammation, obesity. I mean, we can talk forever about the macro environment, right? Microbiome. So you name it, we can keep going on. And then how to put all of that together.
And do you think that is a young patient with myeloma have something to do with the age of their immune system? For instance, to have it younger than 20 years younger, is it related to immune system or only related to high risk to
Germline. Yeah, great question. And we didn't study young myeloma as much, but we're trying to study now African American samples to see if their immune system is altered, and that's why they have a slightly different risk, not slightly, 3 times higher risk of developing MGUS, and whether that alteration is again genetic, ancestry related, or environmental and other things. And we're just starting to do a lot of immune single cell sequencing in those patients, and again correlating it with the genomic aberrations. But I agree with you, young myeloma could be, again, just like inherited familial risk, could there be a risk of a potential germline that leads to that, or other alterations that lead to that early event in those patients?
So we have a more technical question about the ability of your sweet-seq to capture bone marrow myeloma cell clonal dynamics in circulating plasma cells.
Yes. So what is it capable to detect?
What is the ability of the sweet-seq?
Yeah, maybe you can remind us the SwiftSeq technology approach, and Tom is asking if you can get the clonal dynamic tumors.
Yeah. So SwiftSeq is single cell sequencing with BCR sequencing. You can apply it bone marrow, peripheral blood. You can apply it on anything. And because it's single cell, you can really understand the clonal dynamics. And at the single cell level, if you do serial samples, the nice thing about blood is it gives you that information constantly, right? So I can do it every 3 months, every 6 months, whenever we want to really look at the dynamics. So yes, the answer is yes, it can absolutely be applied.
It's RNA single cell.
It's single cell RNA sequencing, yes.
So you can get the clonal evolution of the at the transcriptional level.
Yeah.
Signatures, but yeah, you get mostly the translocations.
Yes, we do have now data on the DNA if you're asking single cell whole genome sequencing, and that's coming up soon.
And you didn't present this because you have too many things.
We can't, yeah.
CTC is the cancer discovery, very, very nice.
The minimum seq, yes, that's another paper.
Molecular profile of patients based on CTC at diagnosis, for example, and do whole genome sequencing with as low as 50 cells, I think.
That's correct. So this was whole genome sequencing, circulating tumor cells as low as 50 cells. We can do it now with less than 50 cells, which is the BioScribe technology, but with 50 cells, which is the minimum seq paper. That was the cancer discovery paper from a few years ago. And we actually are applying that now in clinic. Yeah.
So do we still need bone marrow?
The future is there that maybe we don't need bone marrows, but I think, again, the bone marrow can give you the information of the spatial interaction of the tumor cells with the immune system, the non-immune cells, microenvironment, the stroma. So if you ask questions of persistent cells, of mechanisms of resistance, you may need that. But for clinical factors, hopefully less and less requirement of bone marrow biopsies.
Are you able to look at this spatial heterogeneity? I mean, you guys in the US do bone marrow biopsies all the time, while we do just aspirates, and so we don't have this possibility, but it seems to be very challenging. So we haven't seen that much. Madav published some stuff, the German team as well, I think, but it seems to be very challenging.
Yeah, so it is hard to do transcriptomic data on bone marrows because they're decalcified, so you really mess up your DNA and RNA a lot. However, at the protein level, we have really nice data. So we did, and this paper hopefully will be out, it's in revision, but we presented it in ASH last year with IMC, which is cytoph basically, but on a slide instead of cytoph by flow. So now you can have 30 antibodies, at least for one section, and then you can have different sections, different 30 antibodies, and then you can do the 3D resolution. And now you can ask questions of stroma, immune, as well as tumor cells in the same compartment. And we did it for the CAR T samples, pre and post, just to look at signatures of interaction between the cells at the spatial level and how that correlates with CAR T response and resistance. So I'm happy to send you that data. I didn't show it in this presentation, but happy to show it next time. And then we're applying that now with spatial transcriptomics using Xenium. So happy to collaborate with you on that one. And then going back to as many samples as we can so that we can really understand clonal evolution. I think for spatial, the nice thing is you can look at the tumor and immune and non-immune at the same time and really ask questions from samples that are as old as 15, 20, 30 years ago.
And perhaps look at the hypoxia and how much, right, some cells can be in very hypoxic parts of the marrow. Yeah. Perhaps the T cell don't go up, something that explains why we're not able to kind of eradicate it.
Yeah, absolutely. It goes back to hypoxia and CXCR4, my favorite two things from 20 years ago. My initial work.
And I was wondering also, with all the possibility to anticipate transformation or progression, what is the place for imaging, to your opinion?
Yeah, so clinically, of course, we do PET and MRI for PET CT scan and MRIs for many of our patients. And we have not even looked at that data and looked at whether we can add it into this whole model of, multi-dimension AI modeling of everything. But I absolutely agree. I think we need better imaging modalities. Currently in the US, we only use either a PET CT scan or an MRI. We cannot do both. While you probably need both, and we need better imaging modalities. Again, imaging hypoxia, imaging in a much more concise way what's going on in the immune and non-immune microenvironment is so critical.
We can imagine that your myeloma-like score should be somehow correlated to imaging. Yeah. And maybe it also be possible to have a follow-up of patient with once biopsies, one imaging, and to have every 6 months, every year. I don't know exactly, I'm not treating any patient, so I am purely in the lab. But to my opinion, I think it could be of interest also to have an idea about the imaging. What is it is used at the stage of myeloma, but never before.
So we image a lot of patients with MGUS and smoldering myeloma now. So we have a lot of imaging data, and we have not even started to look at all of that data. I mean, we say yes, negative for lesions, but negative for lesions does not mean that the bone marrow is not replaced, that you cannot understand from the MRI, AI signatures. And this is where AI can help, because images with AI is so easy to do. So it's on our list. Just need enough postdocs to come and work with us.
And you have the 7 Tesla MRIs for MGUS patients.
Yeah, there you go.
At least smoldering. Oh, well, yes, yeah.
So yeah, I think we're running out of time. So thank you very much again, Irene. I think we all have the hope now that one day we'll cure myeloma and perhaps with early intervention. Thank you for sharing your enthusiasm and all the very interesting data that you shared today. So